This is a video introducing flexible nasendoscopy. It's one of the most commonly performed ENT procedures, and essentially all of the new intake and all of the new ENT SHOs will become confident and competent at doing it, because we actually use this procedure in the majority of patients that we see, both acutely and also electively in clinics. So it's something that's worthwhile using, and use it for the majority of diagnosis of any presentation to ENT, especially in an urgent basis. So we'll just show you the scope here. So this is the flexible nasendoscope. This is usually kept in a surgery centre or on Brook Ward, and it'll be in a sealed plastic container rather than the suitcase, but it comes with a scope on its own and essentially nothing else. What you will need to bring on with you and take with you is some lubricant jelly, a pack of swabs, and an alcohol stirret as well. Make sure you also find the light source. That comes on it's quite a big light source, and it comes on a trolley as well. Onto the scope itself. This is the eyepiece, as you can see here. This is to control the focus, and we'll show you what sort of in and out of focus you obviously will know. Or we can show you that on the camera later. And this is the control here, the finger control, which adjusts the angulation of the tip there. Okay, and there's different ways of holding it. You can hold it this way with the finger control up, so the patient is facing us, and you can
just show us your grip, how you're gripping.
Yeah,
that,
so you're gripping it. So the way I do it is that you see this light lead coming across here. I grip it so with my thumb underneath the eyepiece, fingers across the light lead, and then using the finger control at the top, using my index finger to control it. Other ways, the other way, again, eyepiece facing yourself, but the finger control pointing downwards, and doing it like this, using your thumb rather than your index finger to control the angulation of the tip of the lens. Okay, so there's two ways. Just practice both of those and see which feels more comfortable and natural to you. Okay. So now you've got all the equipment by the bedside. Explain to the patient what you're going to do, that you're using a small camera through the nose to have a look at the back of the nose, down the throat, and all the way down towards the voice box as well. Show them the tip of the camera, and also explain to them that not the entire the fibre optic camera is going to go in. It's about half of it that's needed. Okay. Explain to them that it takes between 20 and 30 seconds. It can be slightly uncomfortable, but it shouldn't be painful. They might be asked to do a few tasks during it, but they're all very simple. If it does become painful, they should let you know, and then you can stop the procedure. It may bring a tear to the eye, but that's entirely to be expected. The light source that you guys will be using on the ward. So this is usually in SAU or whatever's replacing SAU at the moment, which is Tandridge ward. And this provides the light source for the scope, and it usually stays on a trolley just like this one. Okay, and then Alison's going to show you all the features of it and what you need to know for to use the scope properly.
Okay, so you need to make sure it's plugged into the wall is the first thing, and that the connection at the back is nice and tight. The on button is on your far right, and it's actually already on, and the light bulb is the button to press. It kindly says push the button to switch on the lamp. So now you can see that a light has come on.
Great.
You can see that this thing does rotate. So occasionally someone might have moved it, but we always use the same default setting, so generally you don't need to move this. And we can plug our scope into the far left-hand side one, which is where the light comes from. It comes wrapped, and this is a connection port. You literally put it in all the way. It should slide in quite easily, and you can see the light coming on here. If the light's not coming on or it's not bright, check that you've got the connection tight. If you've got it on the wrong connection, it won't go in. If it's too big, the light won't fit right again. So just keep it on the default setting. Check that the light's bright, and you should be fine. Remember to switch everything off at the end.
Okay, so now that you've got good illumination, have a look through the camera at some written words. So usually we use the packet of the jelly tube to make sure that you're getting a clear image and you're able to read the writing. If you're able to see that, then that's in focus. If it's out of focus, you can adjust this here to the diopter of your own vision. Okay, so at this stage, now that you know that the camera's in focus and there's a good illumination, you have to lubricate the tip of the camera itself. So you use that by putting in some lubricant jelly. The way I do it is just essentially putting the tip, but not the actual lens itself, in the jelly and rolling it slightly so you cover the entire circumference of the lens, and then using the alcohol stirret and then rubbing the lens itself directly onto the stirret so that you demist the lens. Okay. The other way to demist it is asking the patient to stick the tongue out and then rubbing it on a bit of saliva. That also works. And now you're ready to do this.
When you're doing it, there's a couple of ways. My grip's very similar to that of Sean now. When we do it, make sure that this is in a straight line so that you know that up is up and down is down. Now the same thing over this side, you can have your hand the other way up, but now it's the other way around. So you've got to understand that the way that you hold your scope will affect the picture. But I always hold it in this position like that. Now, if you're with the patient, you want to actually get really, really close to them, because if you're doing from out here, your levers are much more difficult. So you're then moving from your shoulders rather than from your arms, and you don't really want to move from your shoulders because it's not good at fine movement. I always tell the patient that I'm going to be really close to them for them to sit with their bum back in the chair and sitting up. Naturally, people try and lean back, so I was try and lean back. Now that's going to make it more difficult for you. I want the patient to be sitting up. I always put my finger onto their head and say, sit in an upright position, nice and neutral, and then I put my finger on top of their nose. The reason I do this is because it allows me to judge while I'm looking, if I'm looking down with my eyepiece, if they're moving their head away with my finger. So move your head backwards, Alison, so I know they're moving away from me. So that way I've got some sort of tactile feedback. So I'm going to put my finger on those, and then I support the camera with my thumb, and we'll have a look up the nose. So place it upwards. Now, initially, you want to point upwards in the nose, and then as you can see there, as you come in, you can see the inferior turbinate, you can see a little bit of erythema there, and then straighten my arm out so I'm going down the floor of the nose. And what you can see is it's very small movements, gently passing the scope in, and I'm using my fingers just to slowly slide those, and that's the inferior turbinate to the left of the screen, the septum to the right of the screen. We're coming to the post-nasal space here, and over there we can see the eustachian tube orifice. Now what you can see is with my right hand, if I twist my hand, can you see how the picture twists? So that allows me to move left and right. And now with my finger, so using my finger here, if I push downwards on here, you can see on the camera, so if you just turn around, so you keep the camera exactly where it is, but if on your VR headset, if you turn your head round, you can see we're going down around the corner. There's some bumpiness there at the back of the throat, so that's a little bit of erythema. And a little bit of cobblestoning of the posterior, and here we can see the epiglottis. So here we're at the level of the soft palate. So I'm going to just come back a little bit. So Alison, what I want you to do is you can sometimes get, you can see there's some mucus on the back. So Alison, I just want to say la 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 la.
La 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 la.
And can you see the soft palate there is lifting up here to the right. There's the eustachian tube of it, and that's where the adenoids would be there. So we're going to go round the corner and ask the patient to sniff them, breathe through your nose. We've got the epiglottis. So here with the level of the soft palate, we've got our epiglottis, and we get the patient to say E. And you can see the vocal cords there. We can often also ask the patient to open their mouth and stick the tongue out as far as you possibly can. Try and touch your tongue on your chin, and you can see the patient's moving forward, and you can see how that opens there, and relax. Now blow your cheeks out like you're blowing out a balloon. Good, and relax. And we go down and a big deep sniff in, and that's the piriform fossa in each side. And then when we're coming out, we've got to also be careful. So here we've got to control it with our finger, making sure we're not trying to touch the back walls. As we come into the postnasal space, we're changing the position. There's a bit of mucus on the end as you come out. We're gently trying to come out of the nose, supporting the entire way through the nose, and we're out there.